the acceleration from 0 to 100% of Omicron in the countries where it's already occurred has been very rapid, even a little bit more rapid than Delta, which went from basically less than 10% to 100% in about 6 weeks here in our state. So anyway, some good news, some bad news. We'll talk more about the resistance to treatment in just a few slides. Next slide, please. This was from the New York Times this morning. It's South Africa trends during Omicron. You can see it started to peak on November 24th and is already substantially back down 5 weeks later. There's some hope for us in that. That would be, Delta went up in July and has stayed up all the way through December. So if there is a shorter window for this variant, of course, we'd welcome that. But you can see a pretty quick uptake and down slope over the 6-week period. And then the other thing that's worth noting is the deaths do go up a little bit, but not a tremendous amount. And that's one of the things we're hoping for. We'll see is a much lower death rate with the Omicron variant. And we can talk more about what that means in a minute. On the right, this graph is a little hard to understand. There are 3 different graphs, and they all refer to cases, hospitalizations, and deaths right now in the United States compared to last winter. And so that 100% line that goes straight across is anything below that is less than last winter, and anything above it is more. So you can see the cases are way higher, almost double the number of cases in the US. We're at an all-time high, you saw that, compared to last winter. Hospitalizations just going up a little bit, but I will remind you that there's only about a 2-week interval, and that's what we normally see is a 2-week lag. So I'm going to feel a lot better and I'm a lot more confident and able to predict more. And our epidemiologists will have better predictions, and our modeling team when we have a couple more weeks of data under our belt. You can see that the Omicron, the case curve, the gray one on the bottom right there, well below 50%. But again, it's early, and I like to see 6 weeks of data after the peak to declare victory. But I think we have reason to be cautiously optimistic, and we'd like to see a little bit more data. So Omicron is here. It's serious. In another week or two, it'll be 100% of the cases of the new cases in our state. Next slide, please. This is the data we show every week. The epidemiologists, there's a little bit of a lag. This is a 4-week report, and you can see, not too much of a lag though. You can see cases, hospitalizations, and deaths. And now if you look, you see 33% of the cases are now up to, are in people who've been vaccinated. I have not yet seen the stratified data about boosted or not. We'll have better data on that next week for sure. Actually, I've been on leave and I just came back today for the press conference. Still have a few more days, but then I'll be back full time next week. But you can see the trend in hospitalizations, still great protection against hospitalizations from vaccination. And you can also see that deaths much, much lower in the vaccinated population than the unvaccinated. Keep in mind too, this is the percent of the total number, and there's 3 times as many fully vaccinated people as there are unvaccinated people. So that makes this magnitude of this, 3 times bigger, this difference than what it even shows here in terms of vaccine protection. Next slide, please. So hospitals doing way better. If you look back to December 9th, 716 COVID patients, now only 472. That's the good news. The bad news is really in terms of being overwhelmed, the hospitals are about the same as they were. Remember, this is only COVID patients. They have a lot of non-COVID patients. And I think 472 certainly looks better, but we talked to them yesterday and they are still struggling. They're struggling getting staff. They're struggling covering shifts. They're struggling getting the work done, still have long emergency room waits. and delays in care. Next slide shows you why you shouldn't be overly reassured. The available number of COVID ICU beds yesterday at 3:01 p.m. in the state was 9. I think we had one other week where it was 8 since the beginning of the pandemic. This is the second lowest number of ICU beds we've had. Of course, those are all full by now, those 9, but other people will have been discharged and getting very low on medical surgical beds as well as and basically there's sort of a gridlock because everyone is so full. It's very hard to transfer people from one hospital into Mexico to another one, usually in Albuquerque or Santa Fe or Las Cruces. It's hard to do that right now because our ICUs are still so very, very full. Next slide. Staffing assistance for New Mexico hospitals. This is, the state is contracted with a staffing contractor to bring in more nurses around the state. This has opened some more beds, so we're happy about this. The staffing assistance can be 100% reimbursable by the feds as long as we fill out the forms properly. And the reason we're showing you this slide today is that we had 75 federal people in Farmington and San Juan Regional Medical Center a week ago or 2 weeks ago, but some of those FEMA teams have left. And so that all this shows is a drop in those individuals. And we're working with new contractors to try to bring more nurses into the state. As I mentioned a month ago, I think we have a very narrow window. Pretty soon, everybody in the country is going to be needing to do this. And many hospitals, states, regions of states have joined New Mexico and our continued declaration of crisis standards of care in order to try to make some way of ensuring that everybody gets as much care as everybody can get, given the significant restrictions we face. But we're a long way away from one of us being able to call an ambulance, have them show up at our house, take us to a hospital, let's say for a heart attack, get us into the emergency room immediately, get us to the cath lab within the recommended very short interval that has the best outcomes, and then go to an ICU bed. So we remain up against it in our hospitals, and now the rest of the country will be joining us. Remember that even though Omicron has a lower hospitalization rate, if we have record number of cases, that produces, so half the hospitalization rate, twice as many cases equals the same number of people in the hospital. And that's what we're most concerned about today. One of the reporters asked a question, should we be really looking at cases? Should we pay more attention to something else like hospitalizations? Great question. I can tell you that I've been focused almost exclusively on hospitalizations since August when we started being over full. And that is a key number that I use to see how we're doing in the pandemic. Next slide. COVID-related deaths, they're still at a high rate. We always ignore pretty much the last 2 or 3 data points. And for those of you who watch every week, you'll remember that back in November, and Brianna, if you can point to that 81, there, November 1st through 7th, you remember that number started at 20, and then a couple weeks later it was 40, and then went up to 60. I was kind of shocked to see it up to 80 when I got back from leaving. So that's a high number of deaths. That's deaths per week. So it's over 10 deaths per week. And we're very much hoping that Omicron will have a much lower death rate, or what we call not death rate, but case fatality rate, which is the number of deaths divided by the number of cases. Next slide, please. We're doing well. There's really, really good news on monoclonal antibodies, and there's really bad news. I am assuming you'd like the good news first, and that is that we gave over 1,400 doses of monoclonal antibody treatment over the past week. You can see the data there. Tremendous performance from our delivery system despite their staffing shortages. Again, Presbyterian far and away the leader in their statewide system. Eastern New Mexico, Memorial, Norlea, many of these hospitals always on the list. and Gallup Indian Medical Center. Thanks to our friends there and Gerald Champion for getting these antibodies into people. If you remember, you have to be over 65 or older, sorry. You have to have a positive COVID test and symptoms, and then either you're 65 or older, or you have underlying conditions, or you have obesity, which is an underlying condition. I got confused because I just made a phone call to get somebody some monoclonal antibodies, and I was telling you more about them than the situation. So that is the really good news. But notice at the bottom there, BAM-EDI, 738 doses, Regeneron, 620 doses, Sotrovimab, 70 doses. And the problem with that is that we are now learning that both BAM-EDI and Regeneron are not effective treatments against Omicron. And so with us being over 50% already, we're in the process of diverting all of our resources to other options than those two. Huge problem though, because that's, if I'm doing my math correctly, 1,758 cases out of 1,420 or so no longer will be effective with forward use as Omicron takes over. The next slide, our pharmacist, Courtney Lovato, who's just fantastic, did a great job making this chart for us this morning. And so let me go through the chart first and we'll talk about some of the details. Paxlovid, we've talked about that last month, new oral agent, 88% reduction in hospitalization and death. You only have to take it for 5 days. It has to be the treatment has to be started within 5 days of your test or your symptoms. The bad news is we're currently only getting 170 courses from the federal government. The good news is that they're doubling their orders for that, but again, doubling 170 only gets you to 340 and doesn't make up for the gap we're in experience with the loss of BAM-EDI and Regeneron. Remdesivir, we've been giving remdesivir in this state for 2 years now, doing a great job with that. You can see that it is 3 doses. They're an hour to 2 hour infusions on 3 consecutive days, 87% reduction in hospitalizations. And there's no allocation. So hospitals can order as much of this as they want. There isn't a shortage right now. There could be soon. And the thing about it though, is that 3 separate 1 to 2 hour infusions compared to the 1 infusion of Sotrovimab is not favorable, especially for just a 2% improvement. If we had an unlimited supply of Sotrovimab, we would not be even thinking about using remdesivir because it puts a real tax on hospital personnel, and that's where the majority of where this would have to be given. But we do have a supply, so we're gearing up. And I think our Albuquerque hospitals are meeting this week in COVID patients. By Friday, we'll have a plan for how we're going to divide up this work. Sotrovimab, that's the one that's the best and the only now monoclonal antibody infusion that significantly reduces hospitalization and death with Omicron. It's another IV infusion, only 30 minutes. And we have 174 courses. So what I'm doing here is I'm looking at 174 plus 170 is 334 and thinking that's a big gap to get all the way up to 1,428 doses in a week. So that's where we think remdesivir can help. And of course, we're working really hard to increase our federal allocations for the oral drug Paxlovid and for more Sotrovimab. Now, molnupiravir, while I was away, got approved by the FDA. It only provides a 30% reduction in the chances of hospitalization and death. Of course, if you're one of that 30%, it's 100% of you that doesn't have to go to the hospital or that doesn't pass away. And so there is some benefit there. We are going to use it, but we would rather focus our energy and attention on the higher benefit drugs. It too is an oral agent, best to get treated within 5 days, only need treatment for 5 days, distributed by the federal government. And there's more of that available precisely because it's less effective. So what does this mean for the average viewer or reader? Well, number one, we are having to control where and how we prescribe some of these things. Paxlovid, for example, we're focusing on counties that don't have any access to MABs. And so there is a nice website. If you go to our website and click on COVID-19 treatment, there's a couple new pages that came up in the past couple of days that explain more about these drugs and courses and how to get them. The feds also have a website for monoclonal antibodies, but we are going to be in a tight spot for approximately 2 to 3 weeks, maybe longer, until production of Paxlovid, sotrovimab substantially increase and availability increases. So if you are having trouble finding monoclonal antibodies, particularly in the next 2 weeks, this will be why. And we are working very hard to bring up a temporary remdesivir, even though it's 3 times as difficult, in order to try our best to fill that gap until production improves. So this is a really important slide. Other than hospitals, I think this could be our second most important pain point. You could argue it's our first most important pain point, because if we don't treat people with these agents, then we'll have more hospitalizations, and that will make it even more difficult. So we wanted to just let you know what was going on. And typically I think most emergency rooms in the state of New Mexico now are administering some form of monoclonal antibody, but of course, ER waits are quite long at the present time. Next slide, please. So I'm going to turn it over now to Laura, and Laura and I split up the responsibility of Christine today. And so in addition to the drugs that we have to treat COVID, of course, we have lots and lots of other options, and Laura is going to be walking us through that, and I'll be back at the last slide, and then we'll open it for questions. Laura.
All right, thank you so much, David. So yeah, I mean, everything you've just said, David, and just the concern about Omicron, how infectious it is, 10 times more infectious than the original. I think we're all wondering, well, what can we do? And I think we're going back to always that we do have tools to fight COVID. And let's just start with the first one, which is vaccines and boosters. It's really exciting what David just shared, about the data showing that people who are vaccinated and then get boosted have a much higher rate of being able to prevent getting Omicron. So that's really something we want to keep on encouraging everybody to get their boosters if they haven't gotten their boosters, and if they haven't gotten their primary doses, go get your primary doses. So it's our best way, so that if we are, it's so infectious, if we do get Omicron, well, it's going to be a much more milder disease, and our vaccines and boosters will help prevent hospitalizations and death, and even having to get a therapeutic treatment like monoclonal antibodies or medications. So we wanted to just go over with everybody again all the different vaccines and boosters you can get right now. And this is a long list, and so don't worry, we also get confused sometimes, and actually, new vaccines and booster recommendations are coming out every day. In fact, just yesterday, several new recommendations came out, and same with even today. So let's just start with people who are 18 and over. Anybody 18 and over, just remember you can receive any COVID-19 vaccine and booster. We currently have the Pfizer series, so the Pfizer primary series, so your first 2 doses of Pfizer, and then you can then get any brand of booster dose 5 months after your primary series. So that's 3 doses in total. The same thing with Moderna. Moderna is actually, you can get your Moderna primary series, those 2 doses, and then 6 months later, you can actually get any brand of booster doses after that primary series. The same for J&J. You can get your first dose of J&J, and then any brand 2 months after your first dose. So I know it's hard to keep track of all those doses. One of the things that did come out per CDC, they do recommend Pfizer and Moderna over Johnson & Johnson in most situations. So just remember, if you got J&J, you can also get a Pfizer or Moderna, and vice versa. You can mix and match your primary and booster doses vaccine brands. It's okay to do that. And it's so, like, let's say you get to a vaccine site and you're like, oh darn, I wanted to get Moderna because I got Moderna last time and there was Pfizer. You can go ahead and get a Pfizer. It's just as effective for your booster. This is new, new updates, or, within the month, past month, individuals 16 and 17-year-olds can also, get boosters. So many 16 and 17-year-olds have gotten their primary Pfizer doses and then their booster vaccines. And remember, they can't get any other brand, just Pfizer. Your kids 5 to 11-year-olds, you guys can receive only the Pfizer primary vaccine right now. However, yesterday with the CDC, they actually said individuals 5 and older who are moderately or severely immunocompromised should get an additional shot after 28 days that matches their primary series. So if you have a kid who, has some severe immunocompromised status, you can get your child an additional dose to help them with their immune suppression, to help fight off COVID. Then individuals 16 and older, this is another reminder, those who are moderately or severely immunocompromised also should also get a booster. So that's 4 doses in total. People who are severely immunocompromised get one, your first 2 primary doses. Then you can get 28 days later your additional dose. And then, 5 to 6 months later, depending on what doses you got, you can get a booster as well. So that's just a reminder for all of you who are immune compromised. You can get an additional dose and then your booster. And then today, we're just waiting on the CDC. Individuals 12 to 15-year-old age group can receive a Pfizer booster at 5 months. So that's exciting too. That's likely approved today.
Yeah, Laura, it was approved today.
We believe it was I don't know.
No, it was.
Happened
I'm
right
telling
now.
you. That's
That's great.
It was approved today. And now
awesome.
just the Director Walensky just needs to sign it and we're good to go.
Oh, perfect.
Sorry to break in there, but
no, that's great.
We have late breaking news. Thanks.
Yeah, that's breaking news. We were thinking that was going to happen during the press conference and it did. So thank you, David. That's really great news. So that's great for all of you guys out there who are 12 and older who want to get your booster, because remember, the booster really helps to fight off Omicron, serious hospitalizations and death. Remember, they're safe, free to you at no cost. They've been proven to be effective. You can get your free vaccine appointment at vaccinenewmexico.org. You can look for a vaccine. We actually have a lot of openings right now. Vaccines.gov is another site you can look for doses, and going to your local provider or pharmacy as well. So just a reminder, an exciting reminder that we have many tools with the vaccine to help fight off COVID. Next slide. The New Mexico vaccine update, just to kind of keep everyone updated here. Once again, many New Mexicans have completed their primary series, which is the first 2 doses of Pfizer or Moderna and your first dose of J&J. So that's 64.8% of all New Mexicans have gotten that. And then you can see all the different age groups. You can see that, our 5 to 11-year-olds, we really need to keep on working on 5 to 11-year-olds. They're only 17.3% of them have completed their full series. And so just keep on encouraging, kids out there, the parents out there, that let's get our kids vaccinated and protect them as well. For people who are partially vaccinated, so not their full primary series doses, that's 76.7% of all New Mexican. But once again, you can see it gets lower for 12 to 17-year-olds and 28.5% for 5 to 11-year-olds. So let's keep on getting our kids vaccinated. Another new terminology we've been using throughout the pandemic, like fully vaccinated, partially vaccinated. Because of new updates with booster doses, especially data showing that the booster dose with Omicron and other variants is much more effective, we're now calling it up to date. And so we just wanted to start getting everyone used to that term, because up to date means that those of you who have received a booster when you're eligible are considered up to date. And that has a lot to do with, like I said, the effectiveness of the vaccine. And one of the things we did want to mention is that a lot of our school teachers and state employees will be having to get up to date on their vaccines on the 17th. So just reminding everybody, like, you can go once again to many of these sites around the state. They're really open right now, and you can receive your booster dose and be protected from Omicron. Okay, next slide. So another cool tool to fight COVID-19, and the one we've been using for a long time, is masks. Masks are just so great to prevent us from getting, this is an airborne disease, so it will prevent us from getting the droplets of respiratory droplets from Omicron. And also, if we're sick, we can prevent other people that we love from getting sick. So I wanted to just do a quick reminder of the different kind of masks and how to use our masks. So one of the things that, because of the high rate of spread of Omicron right now, and then prior to that Delta, we do have the masking indoors. And we really do want to move away from you have to mask indoors, but more like we're masking indoors. It's a way for us to prevent getting COVID and giving others COVID, regardless of your vaccination status, because it's true that you can get breakthrough cases of COVID, but they will be much more mild. But if you have a mask on and use it properly, you have a less chance of getting COVID. So I just wanted to go through different kinds of masks. What the CDC says is that make sure that a mask that you're wearing just fits snugly against your face. So, those of you who have kids know that, you want to have your kids wear your mask, and then make sure that you have a nose wire on the top. This is a surgical mask. And, some people can use a mask fitter or a brace on top of that. I don't have one, but you can also use a second layer if you want. And I kind of think about it as risk. If I'm going to go to a super crowded place and everyone's kind of crunched together, you really want to be more protected on your mask. So maybe you want to do a second layer, which is a cloth mask. And oftentimes a cloth mask can just help you, stick that under mask in a little bit better. So that's a great way to keep your mask on. And what the CDC has found is that wearing your mask, and sorry, not like this, you don't want your nose showing, or, wear it like that. Just you want to cover your nose and your mouth. The mask, if you wear your mask and it's snug and it's easy to wear, people are more likely to keep it on. I know a lot of people are concerned and they want to use a KN95 perhaps, and you can do that to, let's say, like you said, your risk, you're going on a plane and you're really concerned. So you want to put on a KN95, same way. And then you want to make sure that you really do want to pick something out. Make sure you can get K95s online or at the store. Make sure it's a NIOSH approved one. So there's some approval rating for that. But sometimes I find that the cloth mask is easier for me. But if I smush this down like this on the K95, you can just make sure you're all covered. So that's another mask you can use. And then when would you use this mask, which is the N95 mask? So the reason why you would use that is really most of us who are medical and we're doing a procedure on a patient, doing a test and they're coughing, then we would want to use a N95 mask. Or David and I also use them when we're on a plane, because you just really can't social distance on a plane. So make sure when you're wearing your N95 mask, you want to put those on properly as well, and make sure your mask is really snug, and when you're breathing through, that air doesn't go through it. So just wanted to go through the mask, really choose something that really works for you. and that you feel like you can keep it on all the time when you're out and about and exposed to other people. So I'm not sure if I don't see the slides anymore. Oh, thank you. Oh, because I was doing the demo. Thank you. All right. So once again, masks are widely available. You can purchase them online, and oftentimes like grocery stores even give them out for free, or stores. So great. So that's another tool, our masks. Next slide. And then another tool we have, which is, also, recent, is like the testing. And that's, I know so many of you have been trying to get tests, and there is a national shortage of tests because of Omicron. So as you can imagine, there's a lot of people looking for tests because they're symptomatic or they're exposed. Also, we have recently with our vault testing, this is a national problem where they only have a certain amount of tests. And so it's like being on a line. And then when they're done with, the certain amount that they give to New Mexico or any other state, they kind of cut off their amounts. And so it's not just that group. I know many of you have tried to get tests, and like I said, it's difficult. Oh, start my video. Okay, sorry about that. Okay, so these are some options then that you have. You can do tests that you get at findatestnewmexico.org, curative.com, which is at no cost to New Mexicans. Like I said, vault, but there is a limit right now. And then you can purchase home tests at your pharmacy or online. So let's say you're able to get a home test. Individuals should take a COVID test, whether it's a home test or one that you have to go to somewhere to. If you have COVID symptoms, you've been exposed or potentially exposed to someone with COVID. For the at-home test, at the New Mexico Department of Health right now, thanks to support from the governor and the governor's office and our whole Department of Health team, we are starting a free testing program for high social vulnerable zip codes, as well as places with high case rates. We're starting out with 35,000 tests that we'll start to distribute tomorrow. And we're in the process of trying to get another 1 million more tests. In addition to that, the Biden administration is also working on getting tests that anybody can go online and get a test for your family. So we are, I think, as a state ramping up, as the whole United States as a nation trying to ramp up, but not quite catching up to Omicron just yet, right? If you are able to get a home test, which we think there'll be more and more of, you can get the results in minutes. And I'll kind of walk everybody through that on the next slide. Next slide. So what I'm going to do is kind of give you an overview of what you do with a test, whether it's a home test result. I will use the home test as an example, but I think many of us are wondering, what do we do once we get a positive test or a negative test? And then also in the big pictures of things, CDC just reduced their quarantine and isolation period from 10 days to 5 days. And that big picture is because most of the recent data has shown that most people are infectious 2 days before they get symptoms, and then for the 3 days they have symptoms. So by day 5, most people are finished with their illness. However, all these recommendations that even though they went from 10 days to 5 days, you still have to wear a mask for the whole time, right? So like the 10-day is still including a mask at all times. So let's go through this, and then hopefully, you'll kind of get some idea. I mean, it is confusing to us too. We actually took a long time, and thanks to, I'll just give a shout out to Liesl Gonzalez, our vaccine community coordinator, and the rest of our vaccine and testing team, including David here, to update this, this chart to have it all on one page. So let's say you get COVID and you got a positive test result with COVID. with your rapid home test. So 2 weeks ago, we showed you how to use the rapid home test. So you get a positive result. You should stay at home for 5 days. So I don't know if we can put a little circle around the actual column we're on, but if you stay at home for 5 days, this applies to people who are both vaccinated and unvaccinated. And that's because even though, you know, the vaccine and the boosters help with preventing hospitalizations and deaths, you can still get breakthrough cases. So you want to stay home for 5 days. Remember that when you stay at home, you want to stay in a room away from others in your household. Once again, this is really, really important. You actually do not need to get an additional PCR test. So sometimes people are like, oh, I got my rapid home test, it's positive. Let me go look for a PCR test. You don't need to get that. If you're positive on the rapid test. If you don't have any symptoms after 5 days, so let's say, you know, you got positive, you have no symptoms after 5 days, you can leave your house, but wear a mask for 5 more days. Okay, so that's important because there's still a chance that you can be infectious, not as much as when you first got infected, but keeping that mask on will prevent you from spreading whatever little, you know, amount of virus you still have to others. If you have a fever though, continue to stay home until your fever's gone for 24 hours without, you know, taking Tylenol. So for instance, I'm on day 6 of my staying at home, and I get a fever. I shouldn't leave my home until I'm done with the fever. Another important thing to prevent the spread, because all of this that we're trying to do now is just really how to live with COVID, how to prevent the spread of COVID. Tell anyone you recently had close contact with, which is basically less than 6 feet, you know, and more than 15 minutes. So oftentimes I'm spending time with people for more than that time and less than 6 feet. I would encourage them to get tested or monitor for symptoms so that they can reduce exposure to other people. So that's that column. The next column is the negative test result, or let's say you weren't even able to get a test. So let's go through, you did a rapid home test and you got a negative result, but you have symptoms. And this is also for both vaccinated and unvaccinated people. If you have cough, or, you know, I think all of us know what the symptoms are now for COVID, but cough, fever, chills, shortness of breath, muscle or body aches, vomiting, diarrhea, or a new loss of taste or smell, then you know, okay, I have symptoms. If possible, you know, you want to get a PCR test if you can get one, but once again, we're in a time of shortage, right? So you can also say, these test kits come with 2 tests inside, so I'll repeat my home test again in 1 to 2 days, and that really helps increase the chance that you actually can, you know, get, you know, if you are positive, to check if after 2 days you might get an opportunity, not opportunity, but possibility that you're positive. It's really important if you have symptoms to stay home until you know the result. And if you're positive, when you do that second test or the PCR, then you go ahead and do the positive test results, you know, side. If you're negative, again, then no other test is needed at that time. Once again, it is frustrating if you can't get a test and you have symptoms, assume you're positive and stay home and assume that you do all the same things as if you're positive. And I think that's really important because at the end of the day, we are trying to prevent the spread and live with COVID. Now, let's say you have a negative result and you have no symptoms. This is where vaccination status is actually really important. And that's because they found that people who are boosted and you know, you got your primary series and you're boosted actually have less chance of spreading it to others. So if you just got no symptoms and you had a negative test, you don't really need any other test at this time. But this is the other piece that's really important. If you did have a close contact, with someone with COVID. And that's actually becoming more and more common, as you saw that graph that David showed of Omicron just shooting up. You're just going to have more chance that you were exposed to someone. Then there's two different, kind of quarantine that you do based on if you're gotten up to date on all your vaccines. So every vaccine you're eligible for. So you got, let's say, vaccinated and boosted because you're eligible for that. Then you don't have to stay at home, but you should still wear a mask around others for 10 days. And then if possible, test on day 5 to see if you were actually got positive. And then if you're unvaccinated or not fully vaccinated or without a booster, so essentially not up to date on all your vaccines and booster, then the recommendation is to stay at home for 5 days and then wear a mask around others for 5 more days. Test on day 5 if possible, but at any point, if you develop symptoms, then you stay home and you end up in that back to the have symptoms column. I know it sounds confusing. We will have this, this is recorded, so you can always go back and look at it. We will also have this on the website. Below it says, if you have any questions, please visit our cvnewmexicohealth.org self-test website. And then you can also call our coronavirus hotline. They have this chart as well, and they're all ready to receive your calls. Obviously, try the website first, and then, if you have difficulty, then go ahead and call us. We are trying to make sure that everybody has this information, because I think when we think about how to live with COVID, it's about what we do for each other and our community. And part of that is just trying to prevent the spread when we do know we have symptoms or potentially have COVID. Next slide. And then I will turn it back over to David. So thank you so much for listening in, and I'll just finish up with that.
Thanks so much, Laura. Thanks for your great work. Thanks for taking an impossible amount of information and putting it into a single page so even I can understand. Appreciate that. I like to talk about learning to live with COVID, and I just wanted to give an example. Our family got together this year. Most of my kids ski, and we met in Park City, Utah. And just to give you an idea of how we're trying to learn to live with COVID, everybody who arrived got tested either with a PCR test or 2 home tests 2 days apart within 48 hours of arrival. One of the participants, actually in my extended family, came down with COVID. They were in Austria, so they couldn't fly to the United States, waited until she had several negative tests and then flew and was there at the end of the week. We had a very elaborate schedule of what all the restaurants we wanted to go to, but we scrapped that completely and just cooked some great meals for ourselves and pretty much kept to ourselves. Didn't really go indoors other than the place we were staying. And we had some home tests that one of my grandsons was sick to his stomach. And so just to be sure, he got a home test that was negative and repeated that in another day and a half, and it was negative. So I think it's more complicated figuring out all this testing and how to do it. I did want to emphasize that if you have a positive home test, if it's positive, there is absolutely no need to get any more tests. If the test is positive, it's extremely reliable. And so you don't have to get a PCR. I had a bunch of friends call me over the weekend asking how to get a PCR because their home test was positive, and I talked them out of it. But if you have symptoms, you think you have COVID-19, you've been exposed, please get tested. If you have the positive test and symptoms and any of those risk factors I mentioned earlier, get treatment. It'll be a little tight the next couple of weeks, but we're working on bringing that up to speed. The data about the ineffectiveness of Omicron, ineffectiveness of M. Eddie, and Regeneron against Omicron is very, very new. And so we're moving quickly. What Laura said about being indoors, I told you how our family approached that. We just did not go indoors anywhere other than the place we were staying. And then, of course, the regular admonitions: wash your hands, keep things clean, don't cough into open space, wear your mask, keep your distance, and don't give up on healthcare, even though they're busy. In the outpatient world, they still want to see you, because getting preventive healthcare keeps people out of the hospital. And they're seeing a lot of people in the hospital now who delayed their care. And of course, we always end with another reminder to get vaccinated. And so with that, Matt, I think we're done and we can go to questions.
Great, thanks so much. Tons of activity in the Q&A and in the chat today. And so I want to just make sure that that I'm serving all of you as members of the press corps well. I'm gonna assume that if you're dropping your question into the Q&A or the chat, that's because you want me to ask it for you. And if you don't, please just indicate that, and I will defer back to you. As usual, we'll go with our raise the hand method. So a number of folks, I believe, have already raised their hands, and we will ask questions in order. There were a couple of folks who weren't able to get audio access or had other challenges, and so I'm going to ask some questions for them. And then one other note from one of our staff, her apologies. The team's been working really hard to make these as smooth as possible, but we did make a small mistake, which is that we started the webinar just a few minutes later than the Facebook Live. So if you are in the webinar and not watching Facebook Live, you may have missed the first couple of minutes, but don't worry, it's there for you. As soon as we're done here, you can just go back to the New Mexico Department of Health Facebook page and watch those first couple of minutes to catch anything that you may have missed. So with that, I may actually call on a couple of folks and then get questions organized here, and then ask them on behalf of reporters who would like me to do that. So with that, we'll just start with Julia Goldberg, Jared Ebenreck, and Spencer Schacht, and then I'll ask a question on behalf of Colleen Heil at the Albuquerque Journal. So Julia, you are unmuted. Please feel free to ask your question.
Thank you, Matt. Dr. Grace, Dr. Patahan, I'm one of the people that missed the beginning, so I apologize if you already said this. I will go back, and I sent a bunch of these ahead of time, so you might have addressed them already. But one thing we heard last week from, I think, Christus St. Vincent folks was that if you're using over-the-counter tests, and there's 2 in a box, you should use both because the first one might be negative. And I just was curious if that's, I don't want to say if that's accurate, but I would like to know if you think that is true as well. And then I was just hoping you could also speak to the rising test positivity rate and to what degree that's also a function of the scarcity of tests. I'm not sure kind of how we're supposed to be viewing that number in light of what it's the 7.5% target and where it is right now. Thanks so much.
Yeah, thanks, Julia. Can you repeat? You cut out right at the crucial words of your first question. It was something about if you have 2 tests at home, you should do both. Could you just say that one more time?
Yeah.
So we give you a correct answer.
The city had a webinar with Christus last week, and it was indicated that if you buy a home test that has 2 in it, you should take both of them because the first one might give you a false negative. And that's the first and only time I've heard that. So I'm just curious if that's a thing.
Yeah, I actually think Laura's one pager really, really clarifies that. Typically, the home testing, rapid antigen tests can provide greater accuracy if you do it serially, like day 1, day 3. If it's positive, you don't need to use the other test. I would save that for somebody in your family who needs to be tested now. But if it's negative and you have symptoms, I think Laura had that in her little one pager. If your first test is negative and you have symptoms, I would wait a couple of days, a day or 2, and then retest. What do you think, Laura? Do you agree with that?
I agree with that 100%. So the reason the rapid test, like David said, is much more accurate. If you do get a negative, then a few days later, if you have more symptoms, it can pick up that test as a positive potentially. Another thing, David, that I also recently learned is that a lot of the Omicron is like kind of in your throat, as not as much in your nose. And so some people have been proposing that you do a swab in the back of your throat as well as in your nose to try to see if you can pick up more virus. So that's another option for people to do for the test. But I agree, do the test. If it's negative, wait a few days if you're still symptomatic to take another test.
And then on the rising test positivity, this is one of those multifactorial causes for a higher test positivity, just for people who don't tune in every week or don't like memorizing math formulas. The test positivity rate is the number of cases reported on that time period divided by the number of tests done in that time period. And remember, tests resulted, in that time period. So they're two different populations, but we use it day to day. To get a general idea, we use a week's worth because that sort of washes out differences. So two reasons test positivity can go up. One is that the number of tests goes down, and the other is that the number of cases goes way up. Generally, we actually start seeing a rise in test positivity before we see a rise in cases. It's sort of early warning, if you will. I would say it's due to that rapid rise in Omicron cases that we're seeing in New Mexico. And if you missed the first part, you missed the second slide or third slide, which said we had 2,500 and some cases today. So, and I also think third, and maybe more importantly, and I wish there was a better way to quantify this, but I just gave you this long story about all the tests my family did to get together over the holidays. I would estimate that a total of, 25 to 30 tests were done, and only 4 of them were PCRs. I got a PCR at the drive-through in Albuquerque, and so a lot of those other tests don't get reported. So we do hear from people when their test is positive. We don't hear from people ever really when their home test is negative. And so I think somewhere down the line, we're going to revise our criteria as home testing becomes ubiquitous. Adding 1 million tests to the mix will do that. As it becomes more ubiquitous, I think we're gonna have to come up with a different criteria for test positivity, or even drop it as anything other than a leading indicator for a potential bump in cases. So I don't know, Laura, if you have anything else to add on that, but that's kind of how I think about that, that particular ratio after, almost 2 years of experience with the virus here in our state.
Great. Next, we'll turn to Jared Ebenreck, followed by Spencer Schacht, and then I'll ask a question on behalf of another journalist. Jared, you're unmuted. Please feel free to ask your question.
Thank you. Jared Ebenreck with KUNM News. I asked it a version of it in the chat, but I'm going to ask it slightly differently. Essentially, the CDC guidance announcement last week happened between a holiday break while staffing was low, and the reports are caught public health officials unawares because the CDC recommendation went live without evidence. Then we had the announcement from NMDOH that these would be the recommendations that would be adopted. Today sounds like it's clear we're adopting some version of them. Where's the evidence for these new recommendations? How does NMDOH respond to the coverage that public health officials were left out of the loop with this CDC recommendation? And thank you for your time.
Yeah, good questions. I'll say some things. Laura will probably say some things. We talk to the CDC kind of pretty much every day. I knew about the 5-day quarantine, I think before I left on leave, which was December 22nd. So I wasn't particularly out of the loop on that one. I might have my dates wrong, or maybe I theoretically could have gotten a call while I was on vacation and Laura could have mentioned it to me. But I don't, I think, so number one, I feel like we're generally in the loop. Number two, I feel like it generally is wise practice on our part to go along with CDC guidance, except when we have convincing or compelling data that shows that what we're experiencing in New Mexico is different than what they may be seeing as a nation. So we have a couple recent examples of that. Mandating vaccines for healthcare workers came 2 weeks before the federal government. Recommending boosters for everyone, not just shoulds and mays and the like. That came about a week and a half before CDC recommendations, because we were seeing the waning immunity data and we were following our cases closely. And then lastly, in my ideal dream world, we would have evidence for everything we do, like really solid, hard evidence. And right now, I think the randomized controlled trial where you have half the people isolate for 7 days with COVID and half for 5 days, it just hasn't been done. A lot of the evidence is sort of based on the virus counts in the nose with Omicron versus Delta and over time and things like that. I mean, I don't think they just took a wild guess. I think they were relying on more like biochemical or virologic data than exact, randomized studies. So all through the pandemic, we've made an awful lot of calls without sufficient evidence. I could argue every call we've made hasn't had evidence sufficient to totally satisfy me. But I think, so far our track record has been great, and I don't believe that the CDC would have made this recommendation if they felt like there was any possibility of putting the population at greater risk for getting COVID or greater risk for spread. So new virus, learning as we go. You might remember they started with 14 days, then it was real quickly after that it was 10, and then it was 7. And so we're just learning as we go. But we feel like we have a great partnership with CDC. We give them feedback, they give us feedback. Sometimes they're not happy, like when we just recommended boosters for everyone, but then, they said, but we're going to be making the same recommendation next week anyway, so you're okay. Laura, I know you deal with folks that are in a lot of those meetings more than I probably.
Yeah, so they did meet with us several times and let us know that a lot of people did give them feedback. A lot of the different state health officials throughout the United States did. I think, it's once again, it was partial, like you said, not fully, we don't have the evidence that we can do a 10-day versus a 5-day, but they did look at a lot of the evidence regarding transmission rates. Once again, that most of the transmission happens before the 5 days, and then less transmission after the 5 days. And the mask wearing is so important, right, as a component of that. And then they also took into account the fact that Omicron basically almost shut down New York and, parts of the East Coast, so that, there were people who were just fine with COVID, but they, they were stuck in 10 days. So they also made some of these like social economic reasons for this as well. And then I believe the other piece that was really important is that it's not for every single person and every single setting, right? This is a guidance for the general population. The public education department is looking at it right now for the K through 12. It was also recommended for that group and workplaces, but it's not recommended for long-term care facilities or homeless shelters. That's still 10 days. Places that are at higher risk are still going to be 10 days. People who are immune compromised, it is still recommended that they also, use a 10-day isolation. So it's not for everybody, it's for the general population, but they do have, and I put a link here to the CDC website where they explain the science and frequently asked questions. I don't know if everybody can get to that link. And then also explains a little bit more about quarantine and isolation under the 5-day set.
Hey, Laura, I think you posted that to hosts and panelists. I think I can probably repost it to everyone.
I see. Okay, I do it to everyone. Okay, thanks. Let me do that.
Okay, yeah, it sounds like you'll take care of that. Thank you.
Yeah.
So next we'll turn to Spencer Schacht. Then I'll ask a question on behalf of a reporter, and we'll turn to Chris McKee. Spencer, you are unmuted.
Hi, this is Spencer Schott. Can everyone hear me now?
Yes, sir.
Perfect. Sorry about that. My question goes back to testing. I know we have talked a little bit about there is a lack of tests available. And so when someone goes into a pharmacy or a store to get an at-home test, there are a lot of options at $10, $25, $100 options. Does it matter, or how does the effectiveness of those tests change depending on how much you pay for it? Should you swing for that higher one, or will the $10 one give you an accurate result as well? And then I just have a second part to that question of, we've known a few people who have taken an at-home test that says negative, 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 and then they get the PCR test and it says positive. Are these at-home tests actually picking up Omicron?
So that's really a question about sensitivity. So just a second. So there's effectiveness and there's cost effectiveness. You know, the $5 Buy Next Now cards, at least that's the state's price. You know, I think, for example, 20 of those would be way more effective than one $100 test, the same price. So there's no good study about relative sensitivities and specificities. You'd have to go through the FDA EUAs for each one of them, but generally they're good. You might remember a couple year ago, we were more cautious about home testing because of the low sensitivity. A sensitivity means what percent of the time, if someone has COVID, will the test pick it up? And with one single test, it ran in the 70% range. I'm really going way back here, but I think that was the right number. But then what we learned was with consecutive tests, actually you're more likely to find it. And we hear lots of stories about people with multiple negative tests and then a positive. Sometimes they got COVID, you know, between the negative test and the positive test, they had a different virus and then they were super infected with COVID. But they wouldn't have an FDA EUA if they didn't meet certain reliability criteria. So I would not recommend that people go out and buy the most expensive test because you think if it costs more, it'll work better. Also, I see my internet connection's unstable. So real quickly, and I'll turn it over to Laura. The other thing is, I think Laura's really excellent one-pager kind of covers this. It's, you know, get tested with a home test. If you still have symptoms, get another test. You could get a PCR if you want. You can take another home test, either one. So we think that the lower sensitivity of the home testing, the antigen testing, it is offset by it's really accessible. It's way less expensive, way more accessible to people. You know, you can be mailed the test and get it. So that's kind of how we're thinking about it right now. And I hope that was helpful. As I mentioned, in my big family, I happened to go get a PCR just because I could, because I had the day off. But in my extended family, only what would that be? Maybe 20% of the people who got tested, and my family's pretty gung-ho about not getting COVID. Only 20% of the tests were actually PCR tests, and we all felt safe, comfortable, felt they were reliable. Laura, anything else on choice of testing or accuracy of rapid antigen tests?
Yeah, I think you pretty much covered it. I agree with the fact that, you know, don't go for the more expensive test because anything that was EUA approved is, you know, going to be okay. I think we can't necessarily also test ourselves out of this situation. I think what we're also trying to share is that, you know, if you're symptomatic and you have symptoms that are like really likely for COVID, you know, yeah, the tests aren't 100%, but if you test, you know, like David said, like one test is negative, but you're pretty sure you have symptoms, you test again, then you are more likely to pick that up. And then even if you aren't able to get a test, and I think that's really important to know or note, is that if you feel like you do have, you know, if you have those symptoms of COVID, just assume you have COVID and stay in for the 5 days, right? And then wear a mask for 5 days because maybe you have flu or you have something else that's infectious, and transmissible to others, right? So I think that, it's all about learning to live with COVID. We may not always have access to tests, but we do know when we have symptoms and don't want to, spread it to someone. I think the main thing, David, that I think about when we don't have access to tests is making sure people who are older have an access to tests, because then we do give them a therapy that can make a difference. So I think that's one of the things we're thinking about right now, is how do we make sure people who could get benefit from getting a COVID treatment, make sure we get them tests. So.
Thanks, everybody. I'm going to ask a question on behalf of Colleen Heald at the Journal now, and then we'll follow that up by turning to Chris McKee and then Scott Weiland. So from Colleen Heald, I'm trying to figure out the impact of the CMS mandate affecting New Mexico and 24 other states requiring COVID vaccinations of staff or exemptions by February 28th. The question is, does this duplicate already existing state public health orders, or will it encompass additional types of healthcare facilities not covered by the state requirement?
So I was away, and I didn't hear about the CMS mandate. It sounds like this is an example of New Mexico being 6 weeks ahead on this. And so the one, with healthcare workers, there isn't like a test out option. Although if you get an exemption, then you have to test. But like some scenarios, like right now, state employees, teachers and school staff and healthcare workers are all required to be boosted if they need a booster, if the time is right, by January 17th. Sounds like the feds are focusing in on healthcare workers. So the feds rules and things like that don't have to override the state. I think we just are getting it done sooner. And, a large part of this is we have less healthcare workers than other states do. We have less hospital states than other states do. And so what we're going to see in the coming weeks is a lot more healthcare workers and teachers and others, like we've seen in other cities, getting sick, getting infected, and then reducing our ability to have schools open, cover all the healthcare needs of the state. So I don't know, Laura, are you familiar with that CMS mandate? Maybe you could actually provide some factual information.
I just texted someone from our team who's working on the testing. And so, I think it's exactly what you're saying. We're 6 weeks ahead or several weeks ahead in terms of vaccinating areas with Medicaid and Medicare. I think that's what we've been doing. And I think the one that's the highest one coming up right now is that I believe January 7th, the people who do have to get tested are people who are working in places that have more than 100 people. So that group is also the next group that's having to get tested. And then also the reminder that, if you don't get your boosters on the 17th, for the group that is required to get boosters, that group also has to start getting tested as well. Is that correct, David?
I think so.
Okay.
Okay, thanks so much. Next, we'll turn to Chris McKee, followed by Scott Weiland, and then I'll ask another question on behalf of another reporter. Chris, you should be unmuted. Feel free to ask your question.
All right. Thank you very much, and thank you both for your time here today. I wanted to ask a question related to kind of the multiplier effect. We remember the state, I know in the many press conferences over the last year, the state talking about that multiplier of likely about three additional cases, perhaps it was, for every one confirmed case, but those... Okay, correct me if I'm wrong. I'm sorry. But anyway, I guess there is to say there is that multiplier. We know there are more cases out there than the numbers that come out every day. And obviously, as we're sort of seeing Omicron come out, more cases, more home testing, which wouldn't get reported kind of into the system, right? I'm kind of curious if there is a thought about working on a new multiplier maybe that's out there as we sort of enter this latest wave of the pandemic, because it does feel to some degree like that total case count number couldn't possibly account for all of the virus that's out there. And I know that that's sort of been part of the discussion as is over the last year as it is. So anyway, thoughts on
Yeah,
that?
I think
Is
it's
there a new
a
multiplier?
really good question. So
Thank you.
I think this was a really hot topic 20 when Stanford researchers reported that for every one case, there was 50 cases or 80 cases out there. And, but then the CDC reported, no, it's not that high. It's more like in their data, like for every one case, there's like 4 to, it was 20 or something like that, 24. In New Mexico, because we've done some surveillance studies, we use our labs for people getting other blood tests to run to see who's had COVID and who hasn't. In New Mexico, and the lower this number, the better. So we're doing really well. We believe that for every 10 cases we know about, there may be another 8 cases out there. So we're one of the few states where that multiplier is actually below 1. I think now, though, it's different. It's kind of chilling, Chris, to think of us sitting here saying, yeah, we had over 2,500 cases today. And oh, by the way, there's a lot more out there. I think you're right. I think that multiplier will change with Omicron. I think part of the multiplier effect when it first came out was to try to encourage us to think, oh, we're going to get to herd immunity. But then we realized that coronavirus is kind of like influenza, probably in many ways, where we're never going to have herd immunity per se. And so I think that because everyone's abandoned herd immunity, we've kind of also abandoned the multiplier effect. And in fact, we were talking before the press conference today, as you know, on the website, we still list people who've had their primary series. And then we tell you how many people had boosters. But people who've had their primary series and are due for a booster but haven't had it, their vaccines are no longer up to date either. And so we're trying to figure that all out. But I think for our point of view right now, since we're not going to get to herd immunity, probably ever, and most of us have given up on that, the multiplier doesn't really play into the equations, but it's always going to be true. And with home testing as well, that there'll be more people out there with COVID than we're seeing. Hopefully, and I would beg everybody watching to tell all their friends, if you have a positive test, please report it to the Department of Health. I believe there's an online way to do that.
Starting tomorrow or Thursday, sorry, just
tomorrow.
We're updating, for tomorrow.
So, okay, so anyway, that's kind of a long answer, but I think at this point, the multiplier doesn't get us any closer to anything other than maybe the reality of what's actually going on out there right now. So thanks for raising it.
Thanks, everybody. Next, we'll turn to Scott Weiland, and then I'll ask a couple of questions on behalf of other reporters. Scott, you are unmuted.
Right. Thanks for taking our questions. Scott Weiland with the Santa Fe New Mexican. Yep. Yeah, you touched on the effectiveness of vaccines. And I did read in a couple places that the booster could start losing its full effectiveness after 10 or 12 weeks. But that's not something that's widely reported like many other things about COVID. Do you agree with that, or do you have data on that? And because it seems to be leading to the potential reality that might have to get a booster every 3 months.
I know Israel is talking about giving a 4th shot to people now. They're a little ahead though in boosting. We really are 8 to 10 weeks really after the onset of most people being eligible for boosters. So it's a little early to tell. I think a more important factor is not how long does the booster last against, in this case, Omicron. I think more importantly, it's like how long, what's the next variant going to be, and will the vaccine work for it or not? On our table at the beginning, it's the only question mark left is, what's the susceptibility to the vaccine? So I don't know yet. I mean, I would love it. Someone else sent in a question about how COVID mainly happens in the winter and not so much in the summer. which is true worldwide, but not in New Mexico. And so I think what we're going to do, or try to do anyway, is to come up with a way to shoot. I have all these text messages flashing in front of my screen, and I lost my train of thought. I think there will be monitoring new variants, and hopefully we'll have a longer lead time on vaccine susceptibility. But it's tricky because the only way to know really if a vaccine works against a variant is for a whole bunch of people to get the variant and then look at their vaccination data to tell. And so I don't think every 3 months. I think that would be extreme. That would be a tough nut to crack. But I'm not looking at that. I was kind of settling into, well, maybe we're going to need a couple a year until COVID becomes a seasonal virus.
Thanks so much. Okay, next I'm going to ask a question on behalf of Kaylin Norwood and of KOAT. And obviously, Kaylin, you're always welcome to ask your questions as well. Kaylin's asking about the state's current approach to contact tracing. And we had talked in a couple of previous press conferences about how when we're staffed for, say, 300 cases a day and we're seeing 1,500, it's a difficult operation to run. Her question is contact tracing of less importance now? And if so, where is our focus instead?
Yeah, it's a really good question. And contact tracing is, it's really effective when it's really effective. And then there are times when it's not as effective. So when we talk about contact tracing, it's sort of a combination of two things. It's case isolation, notifying the person they're positive of COVID. And now like 90% of people already know, 99% of people know they're COVID positive. It's unusual for us to call someone who doesn't already have their test result in hand. And that's thanks to the labs giving online reporting access to people. And, you get text messages with your test results now. So that isolation function or notification part of isolation, we have a lot more resources online now for self-instruction regarding isolation. Then after we get through that, we go through, well, who have you been in contact with? Where have you been? What kinds of things you've been doing? And I know you've all heard this from me a million times, but it's like we call people now, and actually a huge percentage, almost 50% of people don't even want to talk to the Department of Health on the phone about their COVID because it's a lengthy process. I mean, it takes an hour to go through all these questions. Two, what we're finding is pretty much everybody is doing everything with everyone everywhere. And so if your hope was to identify a common source of infection, that's completely gone. When there was a lockdown and people had an average of 1.2 contacts, we were able to do some of that, but now we can't. And then the last thing is, if you go back to that slide, you don't have to bring it up, Brianna, but just the case count graph, it goes up and down and up. And, it's impossible to staff any operation with that kind of variability. And so what we're really focused on now, we're still doing it, still calling people, still monitoring the statistics, but what we're really focusing on now is ways to better automate the system. So I would love it if I could, got a text from the DOH said, hey, you probably know that your COVID test is positive. Click here to do to learn more about isolation and what you should do, and then click here to enter in places you've been, people you've been in contact with, or just their email addresses, and then having DOH or email address or phone number, then having that algorithm automatically notify those people, sort of like NM Connect. It would still be anonymous, but you've been in contact with someone who now has COVID. Click here to see what you should do next. So I'm really pushing, since I came to DOH and we saw the declining acceptance and taking calls from us about contact tracing. I'm really pushing for automated solutions, trying to make this more efficient for everybody. And we are investing in that so that most of what you need to know about your COVID infection, you can find out on the phone.
Thanks so much.
Okay, on your phone, I mean, or via text or email. Thanks.
Thanks, Dr. Grace. Next, we'll turn to Bruce Weatherby, and I'm going to ask a question on his behalf. His question is about hospital staffing, and he cites a report in Becker's hospital report this week, citing or listing New Mexico at the top of the national list for hospitals that face staffing crises. And I think he asked a series of questions, but I think the bottom line of these questions is what is the state thinking and doing about the fact that we face a staffing crisis in our hospitals across the state?
Okay, that's a good one. So Bruce, I hadn't seen the report. I went and looked it up. So thanks for sending us the link. I think it has New Mexico tied with another state for number one, with something like 57% of our hospitals having a staffing crisis. So I want to start by saying I think that number's low. I haven't talked to any of our hospitals that aren't experiencing severe staffing challenges. I'm not sure exactly what the definition of staffing crisis was or the surveys. So it's probably even worse than that, than 57%. At the same time, we've been working really closely with the hospitals. We have one statewide system for trying to distribute care to the places where beds are available, vis-a-vis those maps I show you every week with the number of beds available. We've had less hospital beds, less doctors and nurses than most states. We're usually in the bottom third or bottom quarter on those. And absolutely, we need long-term planning. Some of that's being done. There's extensive efforts going on. Probably it would take me too long to describe them. We're building new graduate medical education programs to train mainly primary care doctors in New Mexico through some legislation. We are really working hard through a primary care council to expand primary care growth even further. And others, that task force is looking at doctors, and then we're looking at nurse practitioners as well. The nursing board in our state is doing some looking into nursing supply. I know some of our bigger systems, but I can't give you details on what those plans are today for how nursing is approaching it. I know they're working though extensively with higher education in colleges to expand nursing training program opportunities here in the state. And we did have, we got our second medical school in New Mexico. I believe it was about 5 years ago, 5.5 years ago. They graduated 2 classes of new doctors, many of whom are staying in the state. So it is absolutely a clear need for long-term planning. And I think a lot of people have been on that. Actually, since before the pandemic, the primary care graduate medical education expansion bill came out of the legislature in 2019.
Okay, thanks so much. We're going to quickly jump back to a topic that we had discussed a moment ago and wrap that up. And then Juno and Jeffrey, thank you so much for your patience. I'll get to you next, and then we'll open it up for a second round of questions. So wanted to return to this question about whether and how folks can report positive cases. This is connected to a technology we've had in place for some time, which is New Mexico Notify. And Dr. Patajon has some comments about how we're going to integrate those two functions.
Yeah, so I just wanted to share, can everybody see the screen on
Yep, looks
N95?
good.
So sorry, I've already enabled it. So, but if you haven't enabled it, you can go to NM Notify and basically get connected via your phone. And it basically tracks your phone like as a way to identify if you have been exposed to somebody. I think, David, you said 40% of the population has signed up for NM Notify. The only issue that we're having with them right now is that it is linked to Apple and Google. And so we did ask them last week to turn on the piece where you can enter your own rapid home antigen test data into the system. They were supposed to have done that by Wednesday, which was today. We see that it's not on there yet, but they told us within the next few days, you should have the ability to then enter your own data inside the NM Notify. Right now, if like, let's say you got tested and you want to be able to use the phone to alert your contacts, you can say, get a new verification code and click on that. And then that'll take you to this place here where you put all your information, the time you got your testing date, and then it registers you on the system as someone who's positive, and then it'll notify you and your contacts, right? That you're positive, you're exposed. It doesn't tell you who you are, right? They don't say, Laura was positive, she's your friend. It just goes to the network of where your phone has, been with, in contact with, and it'll just say you've been exposed to somebody who is positive. So that's the way we're using the tracking system. It's more of a community tracking system and not necessarily DOH saying, we have that 5,000 positive rapid antigen tests, that's not what it's for, so.
Yeah, and put another way to tie those two questions together. If everyone in New Mexico had the app, we wouldn't have to do any contact tracing. So you get the notification you're exposed, you go get tested. If you didn't have any symptoms, you'd be done. If you had symptoms and the first test was negative, you'd probably get a second test. But really, it is the ultimate solution. I know that not everybody likes the idea of their phone being monitored. I think it's a great trade-off. I like to know, I'm signed up. So we'd like to encourage everybody to continue to sign up for that.
Thanks so much. I'm going to jump back to the folks who've raised their hands, and I get the sense that there's a little bit of frustration with the pace of things today, only because lots of folks have dropped questions in the chat, and we're going back and forth to those who've raised their hands. Typically, we just go with raising the hands, but I'm doing my best to juggle today. So thank you, everybody, for your patience. We're going to try not to go much longer than 5:30. That's a full 2 hours, but we'll try to get through as many questions here as we can in that remaining time. So for now, I'm going to turn back to Juno Ogle. And Juno, you are unmuted. Feel free to ask your question.
Thank you, Juno Ogle from the Roswell Daily Record. And actually, I was going to ask about the MN Notify. I think you said there were 40% of New Mexicans who had signed up. If you could maybe repeat that, you were kind of glitching in and out a little bit.
Yeah, but I think it's about 37. Last I saw was a month ago, 37%, but we can get that data for you.
Okay. Great. Is that living up to what you had hoped to see at this point of people maybe going to figure in as you kind of reevaluate the criteria and the self-reporting rather than, with home testing becoming more available? How is the NM Notify maybe going to become more important for the state's reporting system? Thank you.
Yeah, it's a great question, Juno. Welcome back. I think it's been a few weeks since we heard from you. I think, as I said earlier, I think ultimately NM Notify is one of the steps to learning to live with COVID. I mean, you think about calling someone up and going through the list of everywhere they've been and then getting all the contact information and typing that in and then sending it out. I think it's a very elegant, very simple solution that basically reminds us when to get tested, and which is what we want. We want to be reminded when we're at higher risk and when we should get tested. So I would love to see it, by June, with all of your help, to have 80% of New Mexico on it. And I think that will increase testing a little bit, but it's pretty chilling. I haven't gotten one yet, but I know lots of people have gotten the notification, and some people who are really, really careful and don't go anywhere, and it's set to notify you if your phone was within 6 feet of another phone for 15 minutes for someone who later turned out to have COVID. So it's pretty sophisticated. And so I'm hoping it kind of really becomes one of the main ways we learn to live with COVID. It helped battle these up and downhill case curves.
Great. Next, we'll turn to Jeffrey Plant. Jeffrey, you are unmuted.
Thanks, Matt. This is Jeffrey Plant with the Silver City Daily Press. I wanted to ask a clarifying question about the self-test guidance. If someone tests positive using an antigen test,
Oh, no.
I think he disappeared entirely from the list of.
Well, if I were going to guess what he's going to ask, he was going to ask if someone gets an antigen test, are you saying they don't need a PCR? And the answer to that is yes. You do not. One positive test is all you need to know you have COVID. False positivity rate, less than 1%.
Jeffrey, I see you on the list now. Was that the question you meant to ask?
Sorry, I really didn't get that. There was somebody speaking over us. Sorry, so you do need a positive PCR test result to get a treatment or not?
So some facilities choose to run a fast PCR at their facility to give treatment. And that's really up to the facility and their criteria. Most of them do repeat the PCR just because it's such a scarce resource, not the PCR, but the monoclonal antibody treatment. So I think you go with what the facility requires. Up until recently, they were repeating. I know UNM, Pres, Lovelace all repeat the test in the ED. We also use those test results later to when we're doing genomic sequencing, that they can get into the mix then. So there are other reasons for doing the test, just trying to get characteristics of sicker people.
Thank you.
Great. So I'm going to ask a question on behalf of Susan Montoya Bryan, and then let's treat this as the beginning of round two. So anybody that would like to ask an additional question, now's a great time to
Hey,
raise your
Matt,
hand.
did we ask Stella's question yet?
It was answered by Laura, I think, in the chat. She was asking
Oh,
about.
okay, good.
Yeah.
She still owes me a cake, by the way. Just saying, Stella. Okay.
Stella, sorry it took us a minute to get to you, but I'm glad you got your answer. Susan's question from the AP is, can Dr. Scrace and Patajon tell us what they're hearing about the return to school? Any concerns about Omicron at some point forcing a return to remote for districts where positivity is high? What would that threshold be? And what are any concerns we may have about the availability of testing for students?
So this is like under intensive daily, many times a day discussion in New Mexico right now. I think what we're learning from other states is the problem with Omicron in the schools is not people infecting each other in the schools, but more staff in particular, too many staff getting COVID infections and therefore having to miss work, not from school, but just from being out and about, often, like I always like to say, doing everything with everyone everywhere. And so, I think that, and one other thing that New Mexico knows, I don't know that any other, I haven't seen it from anyone else, but when we've done our modeling, every time we look at return to schools, results, case counts are always lower with kids in school than when they're at home. And we think that's because it's an environment where you have to wear a mask, you have to keep your distance. And so it's a safer environment than the community at large. And so I don't think we're going to establish thresholds at this point. The discussions aren't over, so I'm not entirely certain, but I think what mainly we'll see is significant shortages of staff at schools that will cause school staff to close down or mainly return to remote learning until they're over this peak. If Omicron is as narrow a peak as we're hoping it is, that could be 4 to 6 weeks, and we can get through the other side of it. That would be good, but we are really looking at it. And I think the last part of your question is there concern about it having enough testing? Yep, there is. We have a test to stay program in the schools where if one kid in the class has COVID, she or he gets to go home. They have to go home and quarantine at home for the 5 days, but the other kids in the class can return to school with regular testing on 1 and 3 and 5 days. And so that will be stressed if we see more student cases in school. I think the number one intervention, like if I had a magic wand and could just intervene and have one thing happen that would be best for the schools and keep the case counts down, it would be to have every parent in New Mexico keep their children at home if they have any symptoms at all that could be COVID. And if we did that, that would do far more to control the spread of coronavirus than any kind of interventions the state could make.
Thanks. Next, we'll turn to Julia Goldberg, and then I'll ask another question on behalf of Kaylin Norwood. Julia, you are unmuted.
Thanks, Matt. I'll be concise, or well, that's probably not true. Dr. Scrace, Dr. Pettihood, I'm sure you won't like this question very much, but the number one thing I've heard from people, a lot of people have said to me in the last week is, look, I'm vaccinated, I'm boosted, everyone I know has COVID, we're all going to get it, you can't avoid it, it's not as dangerous now, oh well. I'm just kind of, I'm sure a defeatist attitude isn't something you're psyched about, but I'm just wondering what your response is to that, because there is sort of this sense of, well, what more can one do if one's done all those things and now it's everywhere?
Yeah, well, I'm okay if that conclusion is true. I don't really care for the attitude, and there's a lot of exaggeration words in there, like everyone I know has COVID and we're all going to get it. But if we can evolve to a milder form of the virus, that would actually be a really, really good thing. I mean, we don't have, press conferences every week to talk about avoiding the common cold, and that's because it's not as fatal. I get the discouragement. I understand how people feel. I know it's frustrating. I think the point that most people are missing is they think of Omicron and Delta and Alpha and everything before that as being all one big lump of COVID, and they're not. It would be more, I think it would help people think about it and maybe be less frustrated if they realize really we're seeing different viruses with different characteristics. They all happen to be a coronavirus. And by the way, we've had, 4 of those floating around for many, many, many years. Probably most of us have had one of them. But I think the frustration comes in with seeing it all as just one big lump of COVID and not these different variants that are coming through. Not to say that I'm not a little bit frustrated with Omicron myself. I mean, it's a lot of hard work getting everyone vaccinated and now getting everyone boosted and seeing vaccinated people get cases, and more of the cases is frustrating to us too. But as long as the long-term solution ends up with an influenza-like mortality rate, it's just going to be mild. Everyone's going to get it, and we just have to live with it. I'm okay with that. But the problem is right now, at least the data we have right now, the mortality rate, death rate is 12 times higher, and hospitalization rates about the same.
Thanks. I'm going to turn to Kaylin Norwood now, and then I noticed there aren't any other remaining hands. So just last call for hands, and if I don't see any after asking and having this question answered, I think we'll turn to final statements. So on behalf of Kaylin Norwood, the question is, can you go into more detail about the distribution for at-home tests? I noticed that DOH had funding procurement of $16,000 in December for rapid testing kits. Is this for at-home testing?
So I'm going to let Laura answer this question, but I like to do math for Laura. And so, and she likes me to do math for her. So I'm wondering if this 16K bought us those 30-some thousand tests you were talking about that we already have. And you can talk about what we're planning on doing for the million. Go ahead.
That's a really good question. So we've had different kinds of funding procurements, so that could be one of them. I'm not quite sure if that's the specific one for the rapid testing for kids, but we have been purchasing for rapid testing for kids, for shelters, for different locations that have needed it throughout the state. And then currently, I can just show you this little quick picture here. This is our social vulnerability index map. So this is a map of all the high zip codes with high social vulnerability in New Mexico. And so we're working with our community partners and different distribution sites throughout the state to try to make sure we can get an initial allocation out for different organizations that are working with social vulnerable populations like WIC and different emergency managers and different community organizations. And then obviously adding more when we get them 1 million doses of tests that were 1 million tests that we're trying to purchase. So we are doing that. So I'm not sure if that 16K is for that, but it is part of the allocations we're doing for rapid testing for kids and a lot of other sites that we're working with right now.
Great. Okay, I don't see any additional hands. So with that, let's turn to Dr. Potterhone and then Dr. Scrace for final comments today.
Okay, great. Well, thanks again for all your questions and all you're doing to promote a safer New Mexico. I just want to once again just remind people that we have such a great tool in the vaccines, and then the layering of the masks and the testing, and then actually staying home and isolating, or preventing ourselves from getting sicker when we get COVID, because I do think that vaccines are working to prevent hospitalizations and death. True that there are more breakthrough cases. Omicron is so infectious, but we aren't, like David said, not seeing as many deaths and hospitalization, at least not for now. And keep on doing what everyone's doing and just encouraging people. I think we're still seeing gaps in especially our Hispanic Latino population and African American population, in the children group, the 5 to 11-year-old group, and younger, the other adolescent groups. So, please ask someone that you trust, that you feel confident in, to ask about the vaccine, your provider or someone to let you know that those are safe and effective for kids, and we can protect our kids and also our elders if we get vaccinated and boosted. So thanks.
Great. Ditto to that. Just one last thanks to Matt Bieber for his role in DOH as our PIO. I do want to do a free advertising. If you're out there as a reporter and think that having the busiest and most exciting job in communications in New Mexico would be right up your alley, call me. We need to replace Matt, and we don't have someone lined up. We also have other jobs in at higher levels in DOH and HSD as well. So if you're one of those people watching out there and you've got a really strong finance background, or you like the idea of working in human services, you can get a hold of us as well. Send a resume to my email address, which is just david.scrace, david.scrace@state.nm.us. I just had to do that because in order to keep doing these press conferences, we need all the help we can get. Second thing is we will not be doing the press conference next Wednesday afternoon. For sure, Laura and I and Christine, when she gets back, are all going to be presenting to the House Appropriations Committee regarding our I'll be HSD and DOH, and everybody else DOH budget. So we're not sure when it's going to be exactly yet, and we'll have to let you know as soon as we can huddle together and figure out the date. Lots of conflicts next week with the ramp up for the legislature, but we'll figure out a way to keep feeding you information. And then finally, I really appreciate Julia's speaking what everyone is thinking, like, Uncle, can't we be over with this? We're so tired of it. We're so sick of it. I did everything I could do, and still everybody's getting COVID. I guess my words are just hang in there. I mean, if death rates drop, if hospitalization rates drop, that means we're on our way to learning to live with COVID. It really does. And we're on our way to coexisting with the virus in a state that doesn't hospitalize as many people and take as many lives. So that's kind of the little ray of hope that I'm looking at with my magnifying glass right now. It's a bad couple of weeks to be going on leave, but I'm catching up, coming back. I still think we've got this. I think the New Mexican people know how to jump in and help when help is needed. They know what to do, and I'm hoping that we'll get through this, what hopefully will be a relatively brief wave, and then be able to maybe go on to the next, hopefully, fingers crossed, even milder variant of COVID, and then the even milder one after that. Very similar to what we've seen with influenza over the past 102 years, but only time will tell. We can't know for sure. Hopefully it won't be a booster every 3 months. And hopefully maybe another one, and then maybe things will settle and we'll find out. But appreciate all of you, like Laura said, doing what you know needs to be done. Just the fact that you're watching this to get information and learn more, that really helps the whole state. It really helps us do our jobs, and we appreciate all of you. So Happy New Year. Hopefully one of your New Year's resolutions is to do one more thing you can do to be safer during the time of COVID and keep yourself and your family safe. Hopefully people out there, hopefully like, I don't know what, 18% of New Mexicans made a New Year's resolution to get their first vaccine, or you decided to get the booster, but those are things that we all can do to improve our health and help us get through this. So thank you for your time. Thanks for your attention. Sorry we went so late after working hours today, but this is an important week to get this information out. You all be safe. And don't be afraid to get tested if you think something's not right. Thank you.